clarify as much as possible because we know you guys have a tough decision to make as you go forward over the next few months. And we just want to make that decision-making process as clear and as straightforward as possible for you. This morning, we're going to hear a talk on the realities of diagnostic radiation by Dr. Deb Mueller, who's one of our trauma critical care faculty, who also, through her professional life, has had an interest in breast disease and radiation from that perspective as well. Dr. Mueller is a native of South Carolina. She went to college at University of South Carolina. She went to medical school at the Medical University of South Carolina, and then via an Air Force commitment did her residency here at Wilford Hall Medical Center in San Antonio. Subsequently did a trauma critical care fellowship at UT Southwestern. I'll meet you outside in a second. UT Southwestern, and then came back to Wilford Hall to be on staff and worked with our residents for many years during a time when we had a merged program with the Air Force. Was a recipient of numerous teaching awards, and when her Air Force commitment ended, we were very fortunate to be able to recruit her to join the faculty here, where she has continued to be a great asset to the residency program, both on clinical teaching and also, as you'll see, some research efforts. So with that, we'd like to welcome Dr. Mueller to the podium.
Can you hear me? He said he would turn it on. Okay. So this morning, I want to talk about diagnostic radiation, and it may seem like not quite the sexy surgical topic, but I'm going to try and make it relevant to you towards the end. But to get there, I'm going to have to take you through some history that I think it's important. It's clear that medical imaging has really revolutionized patient care throughout time, and we'll talk a little bit about that. But I specifically didn't call this diagnostic imaging. I called it diagnostic radiation because while imaging is painless to the patient and it's a lot less visual to us that there could be some harm going on, history will show us that ionizing radiation is a carcinogen, and there is some risk to those imaging procedures we perform. And I'll try and go through some risk and try and put them in perspective for some clinical situations at the end. So why do we need to know? Well, the public knows. These are articles that have shown up, and I will say some of the headlines are overly dramatic, but that's the way the media handles most things. And so in the last decade, there's been multiple publications in the lay press about the concerns of the radiation dose from imaging, and we'll try and define, again, those true risks later on. So as a surgeon, you may be used to discussing the risk and benefits of a procedure, but interestingly, every once in a while, someone wants to know, why does my child need that CAT scan, or do I need a CAT scan? And I think you need to be conversant in the risk to lay out those benefits as well, risk and benefits to your patients, because although you may think it's the purview of the radiologist, it typically falls upon the person who's requesting the test. So not only in the lay press, but also in lots of medical journals, this is probably the most cited article when you're looking through this topic, published in the New England Journal of Medicine in 2007, really by two physicists, radiation-type physicists, showing that computed tomography is an increasing source of radiation exposure. And one of their conclusions was that somewhere as high as 2% of all cancers in the United States could be attributable to radiation from CT studies based on the number of imaging studies we're performing today and the predicted doses. So I think it's important to know it for two reasons: to talk with your patients and also to be knowledgeable about the studies you're using. So we'll go first through some history, which is really interesting, of diagnostic imaging and radiation. We'll talk about the pathophysiology of ionizing radiation. How is it carcinogenic? Then we'll move on to increasing exposure and doses. And I'll show you the doses of an average CAT scan compared to other environmental exposures to radiation. We sustain radiation exposure daily from different sources, but it's quite dramatic how much more you get with one abdominal CT scan. I'll talk a little about the research we did here. We do know children, the younger you are when you're exposed to ionizing radiation, the more vulnerable you are to the effects, because most malignancies that could come about from this process are present in a latent form, so 10 to 20 years after the dose, And also, they have a longer lifespan to achieve that cancer. So it's very unlikely you're going to cause a cancer in a 70-year-old using a CAT scan. So the talk will focus a little bit on our youngest cohorts, but I will tell you young women and young men as well in the 20s and 30s are also at risk based on the increased imaging we're doing. But we'll talk specifically about the research we did here in our trauma patients, who everyone who works here knows we're a fan of the CT scanner. And we'll talk about the doses we were able to at least define what some of our kids are seeing with our current scanning. And then I'll try and make it applicable to kind of everyday situations for the average surgeon. So most of you know Wilhelm Röntgen. He was experimenting with cathode rays and energetic particles in different kinds of vacuum tubes when he had painted this cardboard screen with a barium substance and noticed a fluorescence. He locked himself in his lab for about 2 weeks and perfected the technique of X-ray. And he is the one who coined the term X-ray, using X for the kind of unknown quantity mathematically. And we'll still use that term today, despite many people wanting us to call it after him or something different. This is actually a Polaroid taken of the first X-ray he did. You see he forgot to remove the jewelry as well. And it's his wife's hand. So 2 weeks later, after first noticing the effect, he was able to get his wife in there and take that X-ray. And she's heard to have exclaimed, "I have seen my death." Now, what's not as known, everybody knows Thomas Edison in the United States. Well, here in the States, he was aware of some of this technology going on. And he, one of the greatest inventors of all time, mainly known for his incandescent lighting, he was also working on the creation of a fluoroscope. And he's actually credited with developing the first commercially available and produced fluoroscope. So a lot of people know Edison. Few people know Clarence Dally, who is depicted in, this was a newspaper article from 1903. Dally came to him and was just fascinated with the images. So you can see what he was doing there. He would routinely expose his left hand with different fluoroscopes as they were kind of perfecting the development of the fluoroscope. And when his left hand started to show some redness and irritation, he switched to his right. And so he exposed himself repeatedly in the development of the fluoroscope. Clarence Dally went on to require 2 amputations, one at the shoulder, one at the elbow of his arms. He went on to die from cancer, and he is considered the first person in the United States to die from the effects of ionizing radiation. And this article was published after his first amputation, and Thomas Edison gave up pursuit of any more research on X-rays at that time. He supported Clarence Dally for the remainder of his life. Finally, Godfrey Hounsfield. Did you ever wonder where Hounsfield units came from? It's because he's the brilliant electrical English engineer. Worked for EMI, actually, a big record label kind of thing today in the UK. And he had the idea that if you took multiple X-rays in different planes, you could determine what was inside a box. And using computers to reconstruct with all those X-rays. So that's the diagram he kind of sketched while apparently out walking in the English countryside one day. You can see his prototype scanner he built behind him there. He actually originally scanned preserved brain. Then he used a fresh cow brain. And finally, as all good scientists, he experimented on himself and scanned his own brain. This image you see there, so when did CT scanning, when was the first CT scan performed? Any idea? 1978. Oh, a little later. 71, the very first, but good guess. So it's not that old of a technology. It's actually pretty recent when you think about the things we do in medicine. And this is a copy of that first image. It was a woman suspected of having a frontal lobe tumor. And grainy as it may be, I think you can still tell that it was even a good image at that time. So we have kind of the history of development, and what's common to all those things, the X-ray, fluoroscopy, and CT scanning, is they all use ionizing radiation to generate that picture. And ionizing radiation is when energetic particles traveling through space with sufficient energy to remove an atom or molecule or produce free radicals when interacting with water can occur. So it's a certain amount of energy in those particles. And the way it's believed they cause injury and potential their carcinogenic effect is due to breakage in your double-stranded DNA, either single or double-stranded breakages. So what can happen after your DNA is injured? Well, it can be detected and repaired, and that's the most common response. Cells can go on to program cell death. You can sustain a non-lethal mutation that may be passed on to subsequent cell division, or sustain irreparable DNA damage leading to replicational and transcriptional errors. And again, these last two are thought to be why ionizing radiation can lead to cancers. And indeed, of course, it's not that simple. There are those of us who are genetically more susceptible to this effect. So we already carry genes, perhaps, that make us less likely to be able to repair DNA damage. And unfortunately, we don't know who those people are. And so when we talk about risk, I'll ask you to remember that it's really not as simple because the risk is really almost individualized based on your ability and the genes you might carry to repair this damage. So I want to put the history with the pathophysiology. And there are many critical of this particular data, but this is the lifespan study. Over 120,000 individuals who were somewhere near in one of those concentric rings around Hiroshima or Nagasaki when the atomic bombs were dropped. And while those had both high energy, what we call high energy ionizing radiation particles, they were a combination of high and low energy ionizing particles. And so in the furthest ring out, again, dose estimates figured out by physicists, wind, all kinds of circumstances at this point, 70,000 of the people they followed had an estimated exposure of less than 100 millisieverts. And I'll kind of define that term for you later, but I'd ask you to remember that that's the exposure we're talking about, 0 to 100 millisievert when we're talking about kind of the low ionizing radiation risk. So the studies we'll refer to really look at that population. And basically this study now, I mean, they've been able to follow these people through census forms, death registries, et cetera, and they publish reports about every 15 to 20 years. You know, we have 50 years of data now on these individuals. And so they can estimate risk of carcinogenic effects of this low ionizing radiation following their risk compared to a non-exposed population in other parts of Japan. And the relative risk increases in this population for cancers at each decade of decrease in age. Again, going back to children are going to be the highest risk. But what they have shown and what other studies have shown is kind of a linear dose, no threshold response to low levels of ionizing radiation. And we'll look at one of the tables from this. These reports are hundreds of pages. But this would be our kind of 5 to 100 millisievert range estimated as a colon dose to these individuals, 30,000 subjects. And basically what this excess risk calculates out to is about a 2% increased risk of that patient developing all kinds of solid cancers compared to an unexposed person in the same country of the same age. So this kind of is some of the strongest data because these patients were able to follow through that long latent period. But there are critics of it that feel because it involves both high and low energy ionizing radiation that this might not be the best group to compare it to. The other large groups we have to look at include studies looking at large cohorts of people who work in nuclear power plants. They're exposed on a daily basis. And there's a 15-country study of 400,000 workers. And most of those workers, pretty healthy people in general, do seem to have an increased risk of cancer at about a threshold of 20 millisieverts of exposure. So again, we'll keep reminding you of that 0 to 100 millisieverts. But let's ignore all that. Okay, I don't believe it. I don't believe it. It's high energy. I always have to convince Dr. Myers. I don't know if I've convinced him yet. So if you read this book, The Biologic Effects of Ionizing Radiation, which you can order online from the National Academy of Science, there are really extensive literature on medical radiation studies. So over 100 studies looking at patients who received either therapeutic or diagnostic radiation. And it's really interesting to find out what they would radiate. And some of you may remember some of these things. Ringworm of the scalp, peptic ulcer disease was treated with radiation for a while. It's really fascinating what we thought radiation could do. Well, those patients have been followed in various formats. If we look at diagnostic as compared to therapeutic, which I think would be the most similar population to compare what kind of tests we're using, We would look at young women with scoliosis who were really referred to like 14 ortho centers in the United States, and it actually makes a large cohort, and I'll show you their specific data on the next slide. And then also there's a couple large cohorts, both in the northeastern United States and in the UK, of women who were whose fetus was exposed while the fetus was in utero, and they followed those children up with time. But if you look at all the medical radiation studies together, both therapeutic and diagnostic, there does appear to be an excess relative risk ranging from 0.4 to 10 for cancers. And the highest risk is for thyroid cancer, and that should not be surprising as it's considered the most radiosensitive organ in the body. So let's look closer at the diagnostic ones, because I think that's most similar to kind of where we would accept maybe closest to our risks. So for scoliosis, there was actually another study before this of 1,000 patients, and they reported a doubling of the incidence of breast cancer in the women who were having repeated fluoroscopic examination for their scoliosis. This cohort is called the U.S. Scoliosis Cohort, and had about 5,000 patients. Again, their exposure was on the high end of our level. That's 100 millisieverts. But they also had an excess risk for breast cancer. For the in utero, I didn't have time to put all those things down here, but the summary in this report is doses to the fetus in utero of the order of only 10 millisieverts seem to discernibly increase the risk of childhood cancer. So while we've always been concerned about radiating the pregnant female in that first trimester, there is some other risk to them all the way through their pregnancy and to that child. So, as I've admitted, there are some controversies with some of this modeling because of whether it was a whole body exposure, as in Japan, versus a partial body exposure, as in the scoliosis. Does it make a difference if it is instant exposure versus fractionated over time? But in the end, this is the model that's most accepted by most of the organizations that monitor this topic or produce literature on it. The linear dose, no threshold response. That would say that we all have some amount of cancer risk, and it's actually kind of high. If you look through life, about 1 in 4 of us will get some kind of cancer by time we're in adulthood. But beyond that, if you're exposed to ionizing radiation at the low doses, you will increase your risk. Okay, so I've tried to convince you, you can tell me at the end if I didn't, that ionizing radiation causes cancer. So okay, we've known that. Why the concern now? Why is it such a hot topic today? We'll talk about exposure. This is produced by the National Radiation Council on Protection. And what's interesting is in 20 years, the background exposure that the average American sees has changed, has doubled to about over 6 millisieverts per year. And overwhelmingly, the reason is because of medical radiation. And if you look closer into their tables, in 1987, only about 11% were due to medical x-rays. And nuclear medicine is always kept separate. It's considered a different category. Jump ahead to 2006. And they've kind of split it out, have nicer graphics here as well. But if you add it all up, it's about 36% of just background exposure in the United States now occurs from different diagnostic imaging procedures, with fully 24% of that being CAT scanning. This is a chart from that same New England Journal of Medicine article I referred to showing why this is occurring. In 2010, almost 82 million CAT scans were performed. And what's interesting about this is we're scanning about 6 to 10% more every year. But the U.S. population is growing less than 0.5% a year. Why is this? Well, there's been multiple studies looking at increased scanning for various conditions. It's just one I picked. And I picked it because it's from a pediatric emergency room. So again, now we're talking about the people we think are at highest risk. And they just looked back 6 years, went to their radiology records and said, how many people were we scanning each year? And added them all up. And you can see the dramatic increase in both chest and cervical spine CT, but increases across the board in all. Now, okay, maybe they were seeing more patients. No, it only went up 2%. Acuity, because they document a triage acuity on every patient that hits the ER door. No different. So you weren't dealing with sicker patients. They were pretty much the same, and a few more, but we're feeling the need to image more. So we think it's a carcinogen. We're imaging a lot. Let's talk about the doses you see from these scans. So a gray is the unit most people are familiar with to measure absorbed dose of radiation. What a sievert does is take any kind of radiation and convert it to the same factor. So if you had gamma rays and alpha rays or whatever, protons, whatever you want to call it, when you're talking about a sievert, the units are equal. So it converts that. And it's the most common dose you see in the literature. And the effective dose is also expressed in that unit, and it just averages the absorbed dose over all radiated tissues and kind of gives you this lifelong risk. Common doses. So our portable chest X-ray is estimated to give a 0.01 millisievert exposure, and that's why we've never been concerned really about plain film exposure. It's a very, very minute dose. But if you jump to the bottom there, a pediatric abdominal CT is estimated to give 2,500 times the dose of a chest X-ray to a child's stomach. We'll look at more average numbers, but I think this kind of shows you the dramatic difference in the amount of radiation you receive with the scan. And as I mentioned, we're exposed in the environment to radiation every day. If you ski up in Telluride, you're higher, you get more cosmic radiation. It's got uranium-rich soil, so you're going to see a little more there. And so we all go along with these background doses. But you can't get it higher than with scanning, and probably with fluoroscopy and interventional radiology. So this is why it's a little bit concerning when we're scanning so much more. Even if you live around Fukushima, remember the site of the nuclear power damage after the earthquake and tsunami there, your background dose is estimated right now to be 14 millisieverts a year, and they have the kids there wearing dosimeters, and it still wouldn't be as high as many of our CAT scan imaging. Interesting. Well, what about those backscatter? I'm sure some people up there were doing this yesterday, right? Coming through the X-ray scanners. People have asked me about this because this also has gotten a lot of media flack about what is the dose, and but I can show you it's not even close to a portable chest X-ray. So you're pretty safe going through those scanners. You are getting a little dose, but you'd have to go through it about 200,000 times to equal a CAT scan. So even though in the United States, where there's always an entrepreneur, and if you know somebody who has everything, they probably don't have these flexible radiation shielding undergarments. I really can't recommend them for your holiday gift buying based on the data. So average doses of CAT scans. So these are figures that come from the American College of Radiology. And if you go to their website and some patient wants to know how much radiation am I going to see from a CAT scan, this is what they'll come up with. I think it's reasonable to have that information out there. The problem is it's very inaccurate because of the scanners themselves. If you go in and look at a CAT scanner, look at all those numbers up in the corners when you're looking at your images, there are all these different settings that have to be adjusted for the scanner. Milliamperes per second, kVp is voltage, pitch is kind of the example I've given here, which you can see the lower the pitch, the more the slices are tighter together. There's actually, that radiation comes down in a cone. There's a lot greater dose to surrounding tissues as you go. And guess what? Those give us the best pictures. Tighter pitch, higher amperage, bigger voltage produces the best image. But it also leads to a higher dose of radiation. So there was a study produced out of San Francisco this past year where they just basically went around to 4 hospitals in the city, looked at all the doses from chest CT. There was 50% doubling of dose depending on where in the city you went for your CAT scan based on the difference in the settings on the scanners. So average doses are nice, but they're really not as accurate as we'd like to think they are. And again, I think they are improving because there's been so much attention to this issue that many radiology departments are really on top of trying to make sure their doses are adjusted. How do they figure out these average doses? This is a typical way. They have these acrylic phantoms. That would be an adult head and a little baby head over there, and they'll put a little dosimeter in a little pocket and run it through the scanner with the settings and then take out the dosimeter and measure the dose. And these are anthropomorphic phantoms where you can remove a slice and drop your little dosimeter right where the stomach or thyroid is and do the same thing. The problem with these is that is not the average adult size in San Antonio, which actually is a benefit. The bigger you are, the kind of more dispersion of the ionizing radiation you get. But so even these doses, while this is the common way they do it in physics laboratories, do not necessarily hone down on the dose we see. So with all this background, all this concern and issues about dosing, we undertook a project here with the medical physics department to look at the radiation dose during the initial evaluation of pediatric blunt trauma. And we kind of hypothesized it would at least exceed the historical doses that are concerning for an increased risk of cancer. And we did this over 6 months in all patients less than 17 years old who we were available to go down and see. And what we would do is they would come in as an alert, and they would have their primary and secondary survey, including all plain films. We didn't place the dosimeters prior to plain films because the dose is so negligible. The dosimeters went on. The red would correlate with a thyroid. Again, these are going to measure skin surface doses, but I'll tell you how we calculated organ dose in the next slide. The yellow for the chest because of the concern for breast cancer, and then a green one down in the groin. They underwent whatever CT scanning the trauma team felt was appropriate, and then the dosimeters were removed, and we took some body measurements as well. So while we were doing this, our radiation physicists were doing the usual calculations that are done for dose, and they would calculate organ dose and effective dose with this impact patient dosimetry calculator that was produced in the UK and is really the most widely accepted dose calculator, where you put in all your scan settings. But what's different about what our radiation physicists did is you have to, usually there's an age adjustment, but it doesn't, so it takes an average size for that age. It doesn't, you don't enter weight or anything. But we actually measured body circumference and provided weights, and they were able to adjust for that. So I think we got pretty accurate measurements for our doses, both from them. We had 197 kids, and we did have 42% that were in that youngest age group that we were most concerned about. You can see they really weren't that sick. I mean, the ISS was only 6. Most of them had a normal GCS. So how much did we scan? Well, it's really hard to get out of our emergency room without a CAT scan of your head. 97% of these kids got a CAT scan of their head. Next highest was abdomen and pelvis at about 70%, and then the chest and neck in the 60% range, and then also some face scans. So we averaged 3.14 scans per patient, and you see the largest group was 4 scans, your typical whole body or pan scan, the head, neck, chest, abdomen, and pelvis. Some got 6. This is an unfortunate finding as we're going back through the data of basically kids who were moving during their initial studies and then were subjected to repeated head and neck CTs in that 6th category, and we'll see why that's really concerning when we look at doses. So the blue line is our surface dosimeters, all added together, and as you would expect, the more you scan, the higher your surface dose is going to go. The red is the effective dose, so that total body dose calculated by our radiation physicist in the millisieverts, and you can see we approach kind of 30 there in the top range for the total body dose. So if we look at the dosimeters, what's interesting is, I think, most interesting is the neck. So the thyroid's not that deep, right? It's right under your skin, especially in kids. And so these doses are probably going to be closest to what you would expect to measure if you could actually put a dosimeter in the thyroid gland. And you can see it rises sequentially the more and more scans you get, and got up to 50 milligrays, which essentially milligray and millisieverts are kind of equal for this type of ionizing radiation in the patients that got 6. Now, why is this? Well, think about a 2-year-old, and if you've ever sat there while they're lining up the head, the neck, they're putting all those squares, they overlap, and they're spread and scatter in all of those imaging studies. And so once you're scanned, and then you add the face on, you're going to radiate that thyroid with almost all of those scans in a young kid. The chest and groin, the doses rose, but it really for the groin doses depended, did you get an abdominal and pelvis scan or not? There's still a very little bit of scattering when you're getting other imaging procedures, and the same for the chest. Although there is a little more overlap if you look at chest, people who got chest and abdomen and pelvis. If we look at the doses our radiologists calculated independently, you'll see the thyroid dose gets really concerning, over that 100 millisievert threshold for 6 scans. And again, this is because when they calculate organ dose, there's a weighting factor for how radiosensitive that organ is and whether it's thought to develop cancer for ionizing radiation, and the thyroid has the highest weighting factor. So their doses would suggest even higher absorbed dose to the thyroid gland. And our effective doses or total body doses over here went as high as 30. These were the correlations, which all of the sites are surface dosimetry with their other kind of calculation correlated quite well. And so our results pretty much showed that the mean dose, whole body effective dose during scanning in pediatric blunt trauma patients was 17.68 millisieverts. And the previous kind of retrospectively calculated doses in the literature were about 14. So we came out a little higher than the retrospective data, again, that didn't account for body size at all. That was just looking at dosimetry that had been done on scanners. And so it does fall within the range of these values that were concerning in our historical cohorts. If we look specifically at the thyroid, this is a pooled analysis kind of thyroid cancer risk in 5 studies. And the dose range in those studies, again, these were kids radiated or people radiated for tinea capitis, whatever, back in the day. They had doses anywhere from 10 to 90 milligray, and the mean dose was 50, and you can see most of our values fell within that same range. And for breast as well, we kind of exceeded that 16 millisievert average that they showed in the scoliosis cohort in some of our groups that would be concerning for the development of breast cancer. So from our research perspective, our conclusions were these whole body effective doses did kind of reach that same concerning level. The thyroid dose was particularly concerning, and we believe that's from those overlapping scans. And we did show, and I didn't show the graphs here, but the less you scan, and this makes sense, you can statistically significantly lower your dose. And really the cutoff appears to be about 2 scans. If you can kind of keep it down to 2 scans, you can show that your effective dose and a lot of your organ doses drop significantly. Well, outside of that, I found this interesting as I was doing the research. This is a graph of pediatric papillary thyroid cancer. And it's just been growing kind of steadily over the same time since we developed CAT scan. And I'm not going to go there because you can't, but it's interesting that the incidence of some cancers are decreasing these days, but not one of the most sensitive kind of ionizing radiation organs with this papillary cancer. And in this paper, they allude to what could be happening here, and they list ionizing radiation as one of the possibilities. So I want to move on in the last part to talk about radiation protection application. We've kind of talked about, I think we don't concern ourselves with it because we see a lot more things. We stick a needle in somebody, they cry, that's painful, that's hurting them. And I think because it's not a visual thing, oh, it's you just ride through there, it's not going to hurt. We fail to give it credit, but I think I've showed you historically since the beginning of time that X-rays have ionizing radiation and they can cause malignancy, and I do think we need to be thoughtful about our approach, and there is room for physicians to be more careful in their routine ordering of procedures, specifically CT scans. So the 2 big principles when you talk about radiation protection are justification, which implies appropriate imaging, and then once you've decided to image, optimization. So kind of balancing the radiation exposure and your diagnostic yield, and this is really what the field of this is really exploding in kind of radiology technology. When we started our study, it was interesting. We were not necessarily resetting all the parameters to child size a scan. And so the best thing we got was a performance improvement and an attack on that level. There was what we call automatic exposure control on our scanner. So this is a little button you push, it's on. And then what it does is, you see that scout? It takes that body size and it averages it in with the last 150 scans. Well, the problem is that is, look at who we normally scan, 200 plus pound trauma patients all night long, and you get one little 3-year-old in there, and it lowers the dose a little because it takes their body in, but it just averages. So it's not an effective technique. And actually there's documentation showing sometimes it ends up increasing dose. But this is the area where your radiology department, radiation physics are going to come into play. And it's not that easy because as we lower doses, visibility goes back to like 1970 on some things. It's very hard to see the pancreas well on some of our lower dose scans. So we're still trying to find the right balance of lowering dose, particularly in children, while getting meaningful data. Because if you have a meaningless study and then you've radiated them and you need to do another study, that's not really helpful either. But I will tell you that on the horizon is, the mathematicians and physicists, they're just so smart. They have a whole new reconstruction algorithm coming down called iterative reconstruction that I think in probably 10 years, of course, it'll have to get on every new generation scanner, will lower dose and still give you the best pictures. But what I want to concentrate on is justification for surgery. So we'll go through, just a couple examples of everyday things. So appendicitis. I think the question here is, certainly in children or those at higher risk, is there another test with less radiation exposure that gives you the same diagnostic accuracy? And so what I've listed here is kind of a recent review of kind of meta-analysis data of sensitivity and specificity for ultrasound, CT, and MRI. I will say with ultrasound, it's operator dependent. I think it was pretty popular 10 to 15 years ago, certainly at children's hospitals. But it's operator dependent, it's body habitus dependent, and so the sensitivity and specificity varies in the literature quite a bit based on where it was done. But in a young, small child, it can be very diagnostic. So if you have that capability, it may be reasonable to use. MRI, on the other hand, has just been kind of catching on the last 10 years, mainly for pregnant females, who we know that dose was pretty low for their child, that in utero exposure. And actually, its sensitivity and specificity is really, really quite good in the limited studies that have been done so far. Dealing with this issue day in and day out, it's not a scan that I'm familiar with, and I'm looking through the images and so a lot of hesitation to use this is familiarity with a difference in technique. But I would say it's probably the right thing to do for a pregnant female, looking at the data that's out there today. Overwhelmingly, we use the CT scan to diagnose appendicitis, and there are proponents of that for several reasons, and I'll talk about that a little bit more on the next slide. But I think you do need to think about, and really in any medical issue you're dealing with, certainly in the younger, 30 and younger patient population, is there some other study I could do that may be just as diagnostic with less radiation compared to a CAT scan? I think that's a reasonable question for you to think of when you're dealing with surgical problems today. But let's put in perspective. So you're talking to that mom of the 8-year-old, I don't want my kid to have a CAT scan. I've read all this stuff. I've been on the internet, and unfortunately the internet doesn't filter out the good and the bad. It tends to show up some of the dramatic stuff. So I think these numbers are somewhat helpful. That really, if you look at a 5-year-old and kind of calculate it all out, it's still a very low risk that a single abdominal CT would induce a malignancy. Now, I would say if I'm at a children's hospital where they have these great pediatric ultrasonographers and I can get a diagnosis that way and efficiently, I still think that's possibly the right thing to do. But I don't think necessarily doing away with the CAT scan for diagnosis because of a fear of ionizing radiation is the right thing to do. Because if you look, again, these numbers on the second line, the negative API rate with and without CT, that's about 10,000 APIs and a lot of studies coming up with those numbers. If you look at individual studies, that negative appendicitis rate, appendectomy rate has gone down to as low as 2% or 1% in a lot of studies. And those typically are patients who had a negative CT but still had pain, so they ended up getting the surgery anyway. And there's always going to be some of those. But it's kind of dramatic how much it's improved our not operating on people that don't need it. It's cut it in half, which I, as a mother, actually think I'd prefer than worrying about the CAT scan is not to have my child undergo a negative procedure if that's possible. And then there is a known mortality rate of even a negative appendectomy in the literature. And so those, to me, kind of outweigh that top risk of that abdominal CT. Now, that being said, if you're going to get it, you need to make sure the kid is still for it and it's a useful study. And if you have a better alternative that involves non-ionizing radiation or lower doses like ultrasound at a good children's hospital, I think that's reasonable to consider too. But I think these kind of give you a way to kind of put it in perspective kind of for a parent or a patient and in your own mind. Well, let's go to trauma, another example. Well, when you start scanning the whole body, like we showed, the doses jump up. And this study published in the Archives of Internal Medicine are kind of the common rates people are jumbling about today. And I will tell you, if you go back to the controversies I talked about with the risk modeling, these could be different in 5 years. I mean, these are all theoretical risks based on a lot of old studies and trying to plot out based on the dose what would happen, but they are a little higher, certainly than a single abdominal CT. So I think we need to be somewhat cognizant of that. So where could we cut back? Where could we eliminate some scans? Well, if we look at our own data, overwhelmingly the normal scan that we got the most was the neck CT. And what's interesting about that is the incidence of cervical spine trauma, certainly in the very young, less than 5 years old, pre-elementary, is less than 1%. So it's a very rare injury in that group, yet we just feel obligated. Oh, they can't tell me their neck doesn't hurt. Oh, the scanner's right there. And I think a lot of things drive us to wanting to scan that kid's neck. But if you really look at whether they're going to have it or not, it's a pretty low-yield exam. And this has been shown in multiple studies. This particular one looking at 606 patients less than 5. They were able to clear most of them by exam and plain film. So if it was a screaming, crying 1.5-year-old, they just took a lateral plain film and felt comfortable in most cases clearing those kids. They did still have 24% of them that got CT scans, and overwhelmingly most of those were normal. And all of those kids had actually gotten plain film first, and they never had an injury that wasn't actually seen on the plain film. Many of these scans were done before the plain film was read, and so it's difficult to say. But if we look, so you look at that, you look at how many negative neck scans we did in our study, and so that kind of prompted us to look here at does it hold true. And we've just finished a 12-year retrospective review of almost 3,000 kids. We had the same cervical spine injury incidence that you see in the literature, and not a single patient didn't have a clinical finding. Kids that are young break their spine very high, C1, C3. The overwhelming majority present in traumatic arrest, actually. And they would be classified in that 82% with an abnormal exam. They're intubated in the field, full arrest, things like that, or they come in intubated. 9% of them had a facet jump and had torticollis down to one side, and then the other 9% all complained of neck pain. Not a single child in 12 years without aclinical symptoms who had a fracture that needed some kind of stabilization. Yet today, I'm sure there will be some traumas, and we will need to scan their neck. And I think this is where we need to get better with justification. We need to know what we're looking for. I really feel in trauma we adopted a lot of scanning techniques that are very great in adults. Like I love to scan an adult's neck. Oh, I just love it. I used to, in my day, that was 7 plain films. The swimmers, pull harder, Mueller, pull harder. We got to get C7T1. And you spend all this time and still not have an adequate study, and then you go up 2 floors to the CAT scanner because it was a lot farther away. And again, their cancer risk is very low from that particular study. The same with blunt aortic injury. You can't see it on a chest X-ray. A fair number will occur with a normal chest X-ray. They can die from that. We need to look. But actually, really young kids don't get that either. There's not a single case report of a kid under 6 with a blunt aortic injury. So it's kind of discerning which population you're looking at, what they're really at risk for, and what images are really valuable to you and which aren't. And I think that's where we do have some responsibility to improve dosing to our patients. In conclusion, I think the majority of CAT scans are associated with a very favorable ratio of benefit to risk. And I think there's a lot of fear out there, even recently, even some physicians that I think are really going overboard with the concern. But it is professionally responsible to still consider diagnostic radiation potentially harmful and to meticulously minimize your patient's exposure if you're able to. And the Image Gently campaign, which was kicked off by pediatric radiologists, really have some, simple guidelines to live by. Scan once. So if you're going to scan them, make sure you're ready. That kid needs to be immobilized if you're going to take him to the scanner, and so you can limit their imaging. Only do it when necessary, when you really think this is my only way to eliminate this injury. How likely are they to have this injury? Things like that. Only the indicated region. And if you are imaging a child, to make sure the dose has been child-sized. Be happy to try and answer any questions.
Fascinating talk. I lived through the development of these things in my career here. Early on, when I was in the faculty, a close member of my family had possibility of a brain tumor. And at that time, there were only 2 CAT scan machines in the whole U.S. of A. One in Boston and one at the Mayo Clinic. And now we have them, everywhere. One of the things that I've seen in those years, and you touched upon it briefly, but I wanted you to predict the future if you can, is that the MRI gives better images than the CAT scan. In every field that I look at where the MRI is now being used, it turns out to be much better than a CAT scan. And to my knowledge, there is no damage either at the time or in the future for being exposed to a strong magnetic field. Can you see the MRI displacing the CAT scan as the way to get all those valuable bits of information we need to handle patients?
I will tell you, the market is hot for MRI, and certainly some of this literature has prompted heavy MRI advertising to many hospitals, replace your scanner with these MRIs. I think there's still some limits to MRI, and again, they've improved some of that with the open concept, but they tend to take longer, that noise, putting you in the tunnel. A lot of that still, for some populations, won't work well. And the only reason I say, I would have thought that maybe a year ago, but as I'm reading the new reconstructive techniques of these mathematicians to generate the reconstructed images for CAT scanning, I almost think that will end up taking over even from MRI. I'm not real sure, but I don't see MRI completely replacing CT.
Super talk, Dr. Mueller. My concern about MRI, the practical problems with MRI for a lot of these populations you're talking about, is particularly in the children, the group that need it the most, is they have to be really still. And so to get them really still requires sedation. And once you add sedation to a location that is remote, there's a defined mortality that's not calculated there. There will be some kids who die from sedation while getting their MRI. So to me, MRI it's beautiful with respect to images. It's beautiful with respect to its promise, but until it's faster and can be done in the uncooperative patient easier, it'll be there's a risk of MRI. But I have a follow-up question. When you look at all these, when you start to consider all these risks and the data and the small numbers, the small probabilities, it's really hard for humans to actually process all that information and actually come up with what's the risk-benefit on the fly. So it seems like to me there might be promise in the future. The only way you get these images with respect to the beauty of these images from a diagnostic point of view is to use a computer to adjust all those things. It seems like to me that there's opportunity for using computerized algorithms that actually can calculate the probability of some of these things in the future that might actually hone down what's the risk-benefit ratio. What are your thoughts with respect to that?
Well, I do think there's technology that's going to help with some of this by reconstructing. I think the real answer at the true risk of diagnostic imaging from CT will come. It'll be 20 years, though. There are registries now in Europe. So when you get scanned at some hospitals, you're put in this national registry, and they're tracking these and going to document the increased risk of cancers in those particular patients. Again, it has to be compared to an unexposed cohort from the same nation, et cetera, because of ethnic differences, et cetera. So I think it'll come, but I think it's going to take a really long time. These registries just got started about 5 years ago, I believe.
I think that was a very, very excellent talk, and I think it's an incredibly important issue. The other thing I just kind of want to point out is there are people who are potentially at increased risk for radiation exposure. Those are the people who have problems repairing DNA damage. Okay, and we can identify some of those now. So about 10 years ago, Michael Swift called attention to individuals who carry the mutation for ataxia-telangiectasia, and pointed out that those individuals, about 1 out of every 60 Americans, by the way, has an increased risk for cancer with low-dose exposure. The other group, of course, is the BRCA1, BRCA2 mutation carriers. So individuals who have mutations in the BRCA1, BRCA2 have problems repairing DNA damage. We all carry the BRCA1, BRCA2 genes, but if you have a mutation in that gene, you have problems repairing DNA damage. And the irony is, we take people who have the BRCA1, BRCA2 mutation, and we subject them to extensive mammography screening. And what we can potentially be doing is in increasing breast cancer risk in that cohort. So, the alternative, which you point out, MRI, is probably the preferred method for a lot of these patients, screening BRCA1, BRCA2 mutation carriers, for example. So I thought it was an excellent talk. Particularly your reference to the MRI in certain cohorts of patients, I think is very, very germane.
Thank you. Dr. Adela.
Lots and lots of slides, and you lost me in two places. One, all the Japanese people, 100 millisieverts when you were out here in the suburbs. That was just like radiation in general. I even think you made a comment about that this is just radiation that they got exposed to, not necessarily X radiation, correct?
It's considered, so low ionizing radiation is, they were exposed to that as well. They had high energy radiation as well, the people right there, and most of them are not around. But in those more concentric, they are considered to experience the same kind of ionizing radiation effect as you would obtain from X-rays.
So not more beta or any of that?
I mean, there was, but they're exposed to another amount of just the low-level ionizing radiation. Does that make sense? Because it is the same process, it's just more powerful processes. So that millisieverts actually converts all those kind of different factors to the same thing.
And then the other thing is, it seems like everyone mentions cancer and it's written in black, cancer, and they might as well flash up a skull and crossbones. But it seems like those cancers become a catch-all, and then specifically it's mentioned, really thyroid cancer, but use papillary thyroid cancer. And is there another type of, so there's two parts to this next question. Is there another type of cancer that is a specter out there that we don't know about? And if not, if it's just papillary thyroid cancer that we're really concerned about in 2011, why don't we just shield their neck when they're not getting their neck scanned?
Mm-hmm. Well, it's more cancers than just thyroid. The thyroid's I guess the thyroid, you always see the biggest risk because it's the most radiosensitive organ, so that's the one that pops up. But in women for scoliosis, it's actually breast cancer. And a lot of the young women, breast cancer, all solid cancers, leukemia. But there are ones that are more associated with ionizing radiation than others. So it's not just one cancer. Thyroid's easiest to hone on, and because it's the one that shows up most often. What was the second part? See, now
well, so then it begs when you're not scanning a certain area of the body.
Can you shield it?
Yeah, is it really too much trouble just to shield part of it and then unshield it?
No, and shielding does help even in CAT scan because it will attenuate the dose to some response. There's a lot of debate about that kind of in the literature right now, but there are some areas that are looking at certainly breast shielding for women when they're getting an abdominal CT scan, and some thyroid shielding. It can be effective. Remember the things going like this, and that beam's coming out at all directions. So you will have some low dose from the front that you would need pretty much all the way around if you wanted to prevent it completely.
Yeah, I thought it was a great talk. I had a question. You've even answered it with our own data and your own analysis of it. But in the pediatric ER study, where you showed that increase of 400%, and did they talk about an outcome difference with the increased frequency? Based on, well, at least we're doing more, but boy, we sure helped a lot more people.
Yeah, well, they didn't in theirs. They were just looking at the increased factor. But there's a recent, I believe it's the last couple of months in the Journal of Trauma from LA County, which is a fascinating article to me because they actually wrote an article 10 years ago about you should just scan everybody head to toe because you find all this stuff in that. It's a simpler way to do it. And they documented all these little things they found, may or may not have intervened on, but how positive the scans were. And so then this article actually documents how much more they're scanning and how no interventions really, no difference in outcome could be proven with the increased scanning. So it's kind of interesting to emanate from that same facility, but it's very busy and has a big population. And so in that particular group for trauma, it doesn't seem like we're really changing outcomes with our increased scans.
I mean, let's just, talk about the big elephant in the room. We scan people because we don't want to get sued.
Yeah. Yeah.
Okay, and so, this is great data, but, all it takes is one missed C-spine injury, and, the TV lawyers are at your doorstep. So it's going to take protection. It's going to take tort reform and protection to implement some of this stuff.
We have tort reform. We have the best tort reform.
We do, but still, but it hasn't changed. It hasn't changed what we do.
Can I say it's not about lawsuits to me, but it is about the same concept that Dr. Perry's bringing up, which is so we don't have problems recognizing someone when they come in with a blood pressure of 60 and they're ashen and they look horrible. We know they need to go to the operating room. That's not any dilemma. The problem is, where CAT scan has been beneficial, is in the patients who have very subtle or absent clinical findings. And there's definitely a subset of patients who have subtle or absent clinical findings who have real significant problems. It just happens to be a small number of people. That's where it gets that's where the lawsuit is the same thing. But there's really bad consequences to some of those individual patients in missing those injuries.
Yeah, I agree and I disagree. Again, looking retrospectively.
Everybody agrees when they're looking at the patient who's had the undiagnosed problem,
right,
like a blunt thoracic aortic injury, and they die from that. That we all agree.
Mm-hmm. Yeah, and I think that's why, again, when I spoke, I didn't talk about eliminating those in adults, right? But if you've never had a case reported in the literature ever of a kid, a 5-year-old with an aortic injury, why are you scanning their chest? Okay, and I'm going to look for pulmonary contusions. Well, what do we do with those? Are they hypoxic? Oh, let's put on oxygen. Most pulmonary contusions in a kid you can see on a plain film. So there are other ways to get some information. It's how much do you need and where there are areas where I think we can limit based on very good evidence. And I philosophically think if you're going to scan everybody head to toe, I don't really need to show up, do I? I mean, that's the part of the thinking process of becoming a doctor is what is likely to be in my patient and to pick and choose the tests that are best. And it's not always easy, and there is a risk of being wrong if you don't scan them head to toe. But I think you should use the evidence to inform some of your decisions.
It's like there's the camps now. She's like just made a dividing line. The scanner likerers and the scanner not likerers.
So I think so to not make a camp, I think the biggest bang for the buck is in younger children.
Yeah.
That's actually the biggest, and that's actually a good. Your preliminary data with respect to C-spine shows that. With respect to aortic injury demonstrates. In other words, there's a very low probability without clinical findings they will have any injury there. So I think I'm very optimistic in younger kids, and also for the abdominal trauma, I will say that's the group if they do not have clinical findings, they actually do the best with respect to non-operative management anyway. So I think there's real opportunity in young children to reduce the amount of radiation in that subset of patients with some common sense. I think it would be helpful if you had people love an answer. People refer to this as the answer machine. Let's push the answer machine. We need an answer machine that you can push a little computer button and it'll say probability of this is 0.001. Don't scan, Dr. Stewart. And then everyone will say, oh, that's great.
And if they could arrive with their little genome card, we could know what their real risk
We need
is.
a non-ionizing radiation answer machine.
Yeah, I think, Dr. Stewart, I think all you guys are on the right things. There are certain pieces of this. It's not black and white, scanners or not scanners. There are pieces of this where we can be thoughtful and reduce things. I think appendicitis, that you mentioned it briefly, is a great target for that because, 2 weeks ago I'm on call. We've got a trauma patient comes in. It's about time to go to the scanner, and there's somebody on the scanner, and I say, well, who's on the scanner? Oh, the kid with appendicitis. Well, if you already know he's got appendicitis, why is he getting scanned? And there's a 6-year-old that every nurse in the ER knows has appendicitis. The ER doctors know they have appendicitis, but they're getting scans, and a lot of that problem is it's driven by us as surgeons when we consult on these patients. And we could be very selective, and we could reduce the number of CT scans done for appendicitis. It would take work on our part. It would take a lot of effort, but we could cut it down dramatically. And we've shown with our own data that we have not reduced the negative appy rate since 1998, when we scanned about 30% of our patients. Now we're scanning 97% of our patients, and our negative appy rate's the same. And so selective use of CT, you didn't really go into it, you didn't have time, but selective use of CT for appendicitis.
Right.
Whether we use an Alvarado score, and above a certain level we don't get scans, we just operate. Below a certain level we scan because it's an atypical presentation. I don't know, but there's ways we could definitely cut down on this.